So this is a case. We have a 70-year-old female patient diagnosed to have a severe aortic stenosis. On echo, it was a tricuspid aortic valve. The mean gradient across the aortic valve was 52 mm mercury. LV systolic function was good. Patient was in sinus rhythm. Mainly presented with angina on exertion, dyspnea on exertion, easy fatigability. She has a background history of type 2 diabetes mellitus and hypertension. She was recently detected with COVID without any much of a symptoms, and she was admitted around 2 months back with a heart failure. So we thought about this patient. We calculated the surgical mortality score, and the error score was high and such comorbidities. So we planned that she needed a aortic valve replacement, but surgical replacement risk was high, so we have decided to go for a transcatheter aortic valve replacement in this patient. So we did a 3D CT angiogram. We got the annulus of around size of around 22, and coronary CT angio was normal, and we did a angiogram, a CT scan of the femoral arteries as well as the iliac arteries. So that showed normal, so more than 7 mm size of the femoral artery. So then we proceeded for a TAVR from the femoral approach. So initially we did the pre-procedure coronary angiogram just during the procedure. So both all the three coronaries were more or less normal. Then and after that, first we took a three axis, two arterial axis from both the right and left side, and venous axis from the right, and venous axis from both the right and left side also. So we put a catheter. Since we found that the left-sided iliac artery was bigger in size, so we took the left arterial port as the working port, and we put a 6 French pigtail catheter in the non-coronary sinus, and we do the coronary root angiogram, aortic root angiogram, to see the valve morphology as well as the coronary arteries. Then we put a TPI lead from the right femoral vein. Then the next step was going for the crossing of the aortic valve aperture. So we took a M plus AL2 and we directed it towards the left coronary sinus and pointing towards the aortic valve aperture. Since the valve was quite calcified, so we could just make out from the calcification itself. So we took a straight tip software Terumo wire to cross the valve. So after we cross the valve with the straight tip wire, so we put inside the empluage wire, and we exchange the soft tip wire with the extra stiff empluage wire. This is the extra stiff empluage wire, which is kept in the apex of the LV apex. So now after that, we exchange the empluaged wire with the help of another pigtail. The slide is not there. We exchange another pigtail and we put in the safari wire. It's a curved wire like the LA wire for the wire to be stabilized. Then we took a mammoth balloon of the size of 18 into 40 mm, and we put it across the aortic valve over the safari wire. So then we inflated it after inflation, we can see the aortic valve is open. The dilatation of the aortic valve has happened. So during that time, the pressure drops, and after that, we take out the balloon as early as possible. The next, we tried for we wanted to take the navigator device with the transaortic aortic valve. But what we found that when we negotiated the Python sheet and the navigator, we could not pass the sheet and navigator through the left iliac artery. So we thought, we found that the CT report was a bit anomalous, because more than 5.5 mm of iliac artery is sufficient to pass through the navigator device, but maybe the CT report was anomalous. So we planned to do a iliac artery dilatation. So we took a Mustang balloon of size 7 into 60 mm. We dilate the iliac and the femoral artery, and after that, with some difficulties, we could pass the, this is the navigator with the navigator balloon, and where the above which the aortic valve is crimped. So we just passed over, we went inside over the same safari wire. So after that, we took a root angiogram to see the exit position. Generally, we prefer to around 1/3 inside the LV and 2/3 above the in the aortic room. After doing it, this is where this is how we deployed the aortic valve. We used the Merrill my valve, the size, because we found that it was around 22 mm of aortic annulus. Generally, if the aortic valve is tricuspid, we do around 8% oversizing of the valve. And if it is bicuspid valve, generally we prefer not to oversize much. We generally go around the same size of the aortic annulus. So this is, we did the dilatation, and after that, immediately we have to pull out the balloon. Otherwise, it may get stuck. So after dilatation, we pull out the balloon immediately, and also we have to pull out the pigtail catheter, which was in the non-coronary sinus. So we have pulled out the pigtail catheter. Otherwise, the only problem here, it may be sometimes if the sinotubular junction is very narrow, this pigtail catheter may get stuck. So we have to be careful while pulling it out. And after that, we took a root angio. So we see that the coronaries are flowing well, and there is no aortic regurgitation, no paravalvular leak is seen. So this is well deployed. Now our main worry was about, we have dilated the femoral artery. So there may be, because the Python sheet is there, so during that time, we thought that there will be no issue of any bleeding. But when we remove the sheet, we thought that there may be perforation. So we were ready with a peripheral stent, fluency stent, so that if there is any perforation, we'll just immediately do a cover stenting, the fluency stent. So while removing the sheet, so we slightly give small angiogram and to see if there is any perforation or something. So we were lucky, in spite of very small femoral arteries we could do, and there was no any specific definite perforation or any tear. And after that, we closed the artery, the puncture site, with a probe light. So post procedure, the patient was hemodynamically stable, and the echocardiogram showed that the prosthetic valve was functioning normally. The mean gradient was 4 mm. There was no aortic regurgitation, no paravalvular leak, no pericardial effusion. But what we saw was that patient developed LVBB following the procedure. This may be, it is seen that LVBB may be present, especially because of some edema in the septal area, where the edema may lead to edema of the conduction system that may lead to the LVBB. But the regime reverted to normal sinus rhythm with narrow QRS after 5 days, and the patient was discharged on the 6th postoperative day without any complication. And the patient is doing well now, and the symptoms have reduced. So the take-home message is that even if the patient is elderly and she is a high risk case for a surgical aortic valve replacement, we can always go for a transcatheter aortic valve replacement, which is feasible and which we have started doing in our area also. Thank you.
Depressed,